Welcome to our first Q&A session. This was sought about from a lot of the members in the audience over the course of the drug-specific taper series that we were putting together. And I can't thank you guys all enough for tuning into those and coming in with your questions. They've been super helpful in helping us better understand how to service the community and answer everyone's questions. We had over 500 questions come in, which was pretty phenomenal. So we decided to organize them into sections. The sections that we have organized are safety of long-term use, tapering approaches, rate of dose reduction, withdrawal symptoms, protracted withdrawal, taper initiation or pausing, supplements, lifestyle, and women's health. Mark, you can introduce yourself and we can get started.
Okay, thanks Emma for organising everything. Thanks everyone in the audience for turning up and for putting forward your questions. That's a lot of questions. I guess it sort of goes to show that most people are not having their questions answered by their current providers. So my name is Mark Horowitz. I'm a psychiatric researcher and clinician. I work in London in the NHS. I run a deep prescribing clinic there. And I've helped Outro to set up a clinic in America. And I've done a lot of research on how to safely stop antidepressants. And I wrote the Maudsley deep prescribing guidelines with some colleagues in England around the world. And I'm happy to be here to answer some of your questions about stopping antidepressants.
Thank you, Mark. The first question is, should I be tapering off the medication if I'm now in a good place? It seemed to have worked for a while, and I'm now feeling much better. Is there a reason I should stop?
Look, I think it's a complicated question, different for everybody, lots of things to think about. People might just be relieved that they're feeling well for a while and not want to do anything, which I think is a reasonable course of action. I think that people should be aware that there are long-term risks to using antidepressants. Just to consider, doesn't mean you've got to make any abrupt decisions, but long-term use contributes to emotional numbing. We know that 3/4 of people, half to 3/4 report emotional numbing. More than half of people have treatment emergent sexual side effects. That means that sexual side effects that come from the treatment, issues with arousal, with sensitivity, with orgasm. We know that some people will have those issues even after they stop the drugs. Does longer term exposure increase those risks of the long-term troubles? We're not quite sure. There are issues with weight gain. There are issues with sleep disturbance, memory and concentration impairments. There's a series of studies in older people, which means over the age of 65, that there's an increased risk of strokes and falls and fractures and osteoporosis and cataracts and even an early death. And there's a debate around whether that is due to the drugs themselves or whether it's due to other factors that occur in depressed people. No one is exactly sure, but for some of those conditions, there are plausible mechanisms by which antidepressants might have those effects because, for example, serotonin affects platelet aggregation, the way that we clot our blood. And so things like strokes and bleeding risks seem to be very plausibly related to the drugs and certainly not very plausibly related to being depressed. Other issues like obesity, diabetes seem to also be influenced by antidepressants. So there are, I would say it's not true to say there are no long-term consequences to using antidepressants. It doesn't mean you've got to make a snap decision, but I think it's worth, entering into thinking about whether to stay on or to come off slowly.
I think that's a good transition to talking about tapering approaches. So we talk about hyperbolic tapering a lot. It's all over our website. You've thematically covered even drug-specific in our webinars. Do you want to explain to the audience why it's called hyperbolic tapering, our approach to tapering?
Yes. I'm sorry, it's a bit of a jargon phrase. People hear it and their brains snap shut. Maybe I'll just share a picture. Sorry, I think I said I wouldn't share pictures, but I can't resist. Not being able to show hyperbole for a few minutes gives me withdrawal effects. So hopefully you can see a picture here of sertraline, Zoloft. This is a picture of dose of sertraline or Zoloft on the x-axis, and on the y-axis, maybe I'll make it a bit bigger. On the y-axis is effect on the brain. It happens to be the effect on the serotonin transporter, but you can just think about it as effect on the brain. And the key point in this graph, which comes from neuroimaging of people who are taking Zoloft or sertraline, is it's not a straight line, that doubling the dose doesn't double the effect on the brain. So, for example, 100 milligrams doesn't have double the effect of 50 milligrams in terms of effect on the brain. Actually, it's not that big a difference. And even a really tiny dose, like 40, 30, 20, 10, even 5 milligrams of the drug actually has about half the effect of 100 milligrams. People find that very surprising. And the reason for this relationship is the law of mass action. It says that when there's not much drug in the system, all the receptors for the drug are open for business. And so every milligram of drug has a large effect. A bit like the game of musical chairs. At the beginning of the game, it's very easy to find a chair. And so you get this steep increase. As there's more and more drug in the system, every extra milligram has less and less incremental effects, like at the end of the game of musical chairs. And so you get this sort of law of diminishing returns. And this shape is called a hyperbola. Uh, and if you go down by, in the way that a lot of doctors do these days, just say go from 100, 75, 50 to 25 to 0, it causes larger and larger size reductions in effect on the brain. In fact, that last 25 milligrams packs a real punch, and you drop off basically what is a cliff. And so hyperbolic tapering, if I scoot over here, is rather than reducing by even amounts of dose on the x-axis, is reducing by even amounts of effect on the y-axis. So I've drawn kind of lines that are separated evenly between them. And that requires going down by smaller and smaller amounts, down to tiny final doses before stopping, so that that final reduction to 0 doesn't cause a larger change in effect on the brain as the previous dose reductions. And because this graph is a hyperbola, that's been called hyperbolic tapering. And that's where it comes from, basically coming down by smaller and smaller amounts as the dose gets lower. Imagine if you were walking down, if this line was a path, imagine walking down it. It starts off very shallow, you can run down it almost, gets steeper, becomes more dangerous, you go slower and slower, and right at the end you've got to climb down quarter of a milligram by quarter of a milligram to avoid the drop. And that's what it's all about.
Well said. Okay, so broadly, you can answer this question because there's so much for us to go through. Why do some doctors recommend or provide guidance on fast tapers? And what are the risks of that?
So, I would say that most doctors probably provide advice on fast tapers. And the reason for that is it's a bit of a kind of cultural history. So at the moment in America, the American Psychiatric Association guidance on antidepressants says withdrawal effects from antidepressants, or they call them discontinuation effects, a kind of drug company euphemism, are brief and mild, and you can come off your drug safely in about 6 weeks. And so that's what doctors are taught. In practice, most doctors recommend halving the drug for 2 or 4 weeks, often by splitting a tablet in half, and then maybe splitting it again into quarters by taking half a tablet every second day and then stopping it. That's common practice. They do that basically because they've been taught. Why does the guidelines say that? They say that because at the time they wrote the guidelines, they thought that withdrawal effects were brief and mild. And they thought, well, 4 or 6 weeks sounds like about enough time to come off if it's just a few days of symptoms. And the reason why the guidelines thought that is because drug companies did studies of people who had been on antidepressants for 8 to 12 weeks and showed that they mostly had mild and brief symptoms when they stopped their drugs. It's true. Some people have severe symptoms after 8 weeks, but most people don't. And so on the premise, so in other words, coming off over 4 or 6 weeks probably does make reasonable sense if you've been on the drugs for 8 to 12 weeks. Probably is not, for the occasional person it won't work, but it's not bad advice. Of course, the problem comes with reality, as it always does, is that there's 25 million Americans who have been on the drugs for years or longer. Some estimate 2 years or more, some 5 years or more. And there's lots of people who have been on the drugs for 10 years or more. The longer you're on an antidepressant, the more your brain has gotten used to it and the harder it is to come off. And so we know that people that have been on the drugs for 5 or 10 years have much worse symptoms than people who have been on them for 8 or 12 weeks. And so the dangers of coming off too quickly, there's lots of dangers, but the 3 main ones that I always highlight are you can develop akathisia, this sort of restless agitation that can make people feel like they're losing their minds. You can become highly suicidal. We know that unfortunately some people will take their lives in withdrawal. And the third issue is you can develop a protracted withdrawal syndrome, this sort of what looks like a neurological injury or irritation that can last for months and sometimes years, full of all sorts of neurological, psychological, and somatic symptoms. And that's why coming off too quickly can be dangerous for some people.
And you mentioned this earlier when you were talking about the hyperbolic tapering approach, but can we also maybe touch on how modeling your dose reduction hyperbolically tends to minimize the symptoms or perceived burden associated? So those withdrawal symptoms.
Right. So I guess the idea is your brain's got used to a drug, and how do you remove the drug to minimize the disruption to the system? The way, and maybe I'll use an analogy of, people have told me it's a bit visceral, but jumping off the top of a building, being on a drug is like being on the 20th story of a building. And the quicker you go to the bottom, the more trouble you'll have when you get there. So the quickest way to get from the top of a building to the bottom is to jump from the top to the bottom. That's like going cold turkey on a drug. There's a huge change in the chemical balance of the brain when you do that, and that's where the most consequences occur. You can make things a bit easier by going down story by story. Jumping story by story, you might hurt your knees badly, but less so than jumping off the top of the building. But if you go down step by step down the staircase, it takes longer, but the disruption to your system, think about your knees, for example, as you go down each step, is minimal if you do it slowly enough. And the same is true for your nervous system. The kind of slower you go down, the more time you get, the more time you take to adjust to each dose, the less disruption there is. And I guess the hyperbola comes in, that's sort of the shape of the staircase. So if you follow the staircase more carefully, that hyperbola, you cause yourself less trouble. And so it gets harder, it gets sort of steeper and steeper as you get down to lower doses. And that's why you need to go more carefully. So I guess tapering gradually and in the same sort of pattern that the brain expects causes the minimal amount of disruption to the system, and therefore the least amount of withdrawal effects from what we understand so far.
Well said. And I think too, there's quite a bit of interest in understanding. We had a couple questions that are a bit more technical, and now that since we're talking about the tapering approaches, I think maybe cover them. So how would you suggest measuring out smaller and smaller liquid doses? I can't find syringes or tools that will go that low.
So there's a few options when you get down to really low doses. There's a few. So one, you can get a compounding pharmacy to make up a more dilute solution. So if you're struggling with a 1 milligram per mil solution, you can get a 0.1 milligram per mil solution or a 0.01 milligram per mil solution. Or you can do it yourself. You can take a liquid version of the drug and you can mix it with water to make it more dilute. So if you've got a 1 milligram per mil solution, you can take 1 mil of that and mix it with 9 milliliters of tap water, and now you've got a 10 times more dilute solution. The solubility might minorly be adjusted by that, but mostly it's not, because these are mostly aqueous solutions. And so if you shake them, they'll be evenly distributed, and then it's much easier to measure out small amounts. And if you've got even more dilutes, even more concentrated solutions like 20 milligrams per mil, you can just dilute it several times. You can go from 20 milligrams per mil to 1 milligram per mil, from 1 milligram per mil to 0.1 milligram per mil, what's called serial dilution.
We also have some questions about cross tapering. So this question is, my doctor just recommended that I begin a low dose of trazodone to help me with clonazepam 0.5 meg taper. Is this a recommended strategy, or am I setting myself up for future problems by adding trazodone?
Yeah. So it's not possible to get off a drug by using another drug. It's like saying, I'm trying to get off whiskey and I started drinking red wine. That will, Emma used the word switch, which was not in the question, but that's exactly what's happening. So Emma's already understood what's going on here. If you use another drug to manage withdrawal effects, you'll just end up switching the drug. So if you're having trouble coming off clonazepam, the best thing to do is to come off it more slowly. If you use trazodone to make up for it, you'll end up using more trazodone, and then you'll have the same issue with coming off trazodone.
Actually, as the next topic, we're doing rate of dose reduction. A question that comes up often is, I'm going to split this up into two. How do you decide what taper plan or percent by to reduce your monthly dose? But I think on a flip side, something else that we got as a question that came in multiple times was, can you ever change your dose reduction month over month? So if you're going on like an 8% taper reduction, can you switch over to 10 or to 6? And how does that look?
Yeah. So good questions. I mean, actually, it's sort of hard at the beginning, because once you're tapering, you have a good sense of what you can tolerate. If you find that 10% per month is too unpleasant, you might drop it down to 8% or 6%. If you find that 4% per month is very easy, you might increase it. So, the main way to do it is to adjust it to what you feel is tolerable. Everyone's a little bit different. I kind of use this sort of rule of thumb. If people score their withdrawal symptoms out of 10, where 10 means unbearable, I can't live with this anymore, and 0 means, I feel great, I'm doing somersaults in the sunshine. Most people can handle 3 out of 10 symptoms. That's like having a cold. They can live their lives around that. It might not be the most pleasant way to be, but it's possible. Almost nobody can handle 8, 9, or 10 out of 10 symptoms. That means you're going much too fast. And 4, 5, 6, 7 out of 10 generally means you're going a bit too quick and need to slow down. So that's the sort of rule of thumb that I use. The hardest reduction to judge is the first one. If you want to, if you want to be cautious, you can go down at 5% as your first one, or if you're in a low risk kind of category, you might go down at 25%. It matters a little bit about what dose, what drug you're on, how long you've been on the drug, and what trouble you've had in the past. So some people can go down as quickly as 50% per month, and some people need to go as slowly as 5% per month or slower. And it matters a little bit what risk factors you have.
Perfect. Next question, and it's actually in the chat, and it's the next question on my docket here. People frequently, even when I'm having conversations with them about what I do, because I'm so passionate and I'm so lucky to be working here, ask, is there an expiration date on when it might on tapering off an antidepressant? Like, can you ever age out, or can you be on antidepressant for so long that it's maybe not worth coming off? People frequently, even now in the chat, are asking, it's been 20 years that I've been on Effexor. Should I even consider tapering?
Right. Fair question. Look, I think the first thing to say is, yes, the longer you're on a drug, the harder it is to come off. That's what studies show. There's probably a ceiling effect, though. Just taking, say, caffeine as an example, being on, if you're drinking coffee every day for 2 years, you're going to have more trouble than if you've done it for 2 weeks. But to some degree, after 20, you're not that much more dependent on caffeine than after 10 years. So there's sort of a ceiling effect. You get to a maximum. I don't know where it is, but it's probably after a few years. Is it possible to get off after 20 years on? I mean, the answer is yes. As it happens, I was on my antidepressant for 21 years before I got off it. I know from first-hand experience that it's possible to. I've seen people that have been on drugs for 35, 40 years that have come off their drugs. I think it's true you have to do it very slowly. I think the question comes, I've seen people who are in their 80s and they say, well, it might take me 3 or 4 years to come off. I'm already a bit frail. I don't want to be sicker. You might decide it's not worth it. But I think so it's a bit different for everybody. I think it depends on how old you are, how long, it might take, the negative effects of the drugs. But I think for a lot of people, as long as you do it very carefully, I think it's possible for lots of people to come off their drugs, even long-term users.
Now, on the topic of withdrawal symptoms, and someone wrote this question, and I chuckled, honestly, because as I was tapering off my medication, I felt very similarly. Will my mood swings ever end, and will I become a nicer person again? So talking more also on like the air of irritability.
I can guarantee that Emma is a very nice person these days. So compared to her Cymbalta withdrawal days, she's improved immensely. I didn't know her then.
I have.
So, look, mood swings is a very common effect of withdrawal. The chemistry in your brain has been completely mixed up, and one of the symptoms of that is, there's low mood, there's anxiety, there's irritability, there's tearfulness, anger, and mood swings. And yes, your brain will rebalance, people settle down, and yes, you will become a nicer person again. If you were a nice person before, it's like that old joke, the patient says to the surgeon, after the operation on my hand, will I be able to play piano? And the surgeon says yes. And the patient says, well, I couldn't before. So if you're a nice person before, Margaret, then it'll come back, but otherwise.
Caitlin just wrote a question in the chat that I think is very valuable. Any tips from anyone on explaining the particularly the irritability to friends and family that might not have experience, coming off medication themselves?
Great question. So this is a huge issue with withdrawal, is the misunderstanding of people around you about what's going on can lead people to come to all sorts of conclusions. They might say, look, you're getting sick again off the drug. It means you must need the drug. And I guess I would use an analogy to other drugs. People know, for example, if you quit cigarettes, you become anxious and irritable. It's not a sign that you need to keep smoking. It's a sign that the withdrawal effects are unpleasant. You might need to go more slowly off the cigarettes. So I would kind of try to connect it to things that people already understand. People know that coming off alcohol or cigarettes, maybe benzodiazepines like Valium, can cause symptoms. And I would explain to them, well, antidepressants are actually, more similar in some ways to those drugs than you would think. and you can get the same kind of withdrawal effects.
Another question in the chat before I go back to the document. I know we have so many to go through, but this is actually also pretty good, and I wanted to ask this earlier. Can it be common to experience withdrawal symptoms even into early dose reductions? It's like just when you're starting off. I know you were talking about the hyperbolic curve and how, as you get lower, closer to that level of efficacy, like at a therapeutic levels, even if you're going from 70 milligrams to even 60 of your dose, can it be common to experience withdrawal symptoms then?
Yeah. So the answer is you can. There's a few reasons why. The graphs I show are averages across people. And so some people, the curve might turn at different points. And number two, some people are more sensitive for lots of different reasons, maybe because of how long they've been on the drug for, because of multiple switches. And so that even small reductions can cause trouble. I always say, the graphs are a bit helpful. Some of the risk factors are useful, but ultimately it's the person's experience of withdrawal that's the main guide. So if you're experiencing withdrawal, that's a sign you're going too quickly. You need to go slower, even if it's at higher doses. So it's always the most important thing.
The next question is about discerning between side effects from the medication that you're still taking and the withdrawal effects of the lower dose that you're now taking. So as mirtazapine appears to have different side effects depending on the dose, for example, the increased drowsiness, how can we distinguish between the side effects of mirtazapine versus the genuine withdrawal symptoms of coming off?
Yeah. Good question. This comes up a lot. It can be very confusing. For most drugs, actually this comes up a lot. A more general question is this side effects from the drugs? And therefore, should I get off them quicker? Or is this withdrawal effects from the drugs and therefore I should get off them slower? In general, the answer is the second one. When people are getting more trouble as they come down, it's not really possible for you to have more side effects at lower doses. That doesn't make sense. But it certainly is possible to have more withdrawal effects at lower doses. So generally the answer is it's withdrawal effects. Mirtazapine might be an exception to that because it's got a reputation of being more histaminergic at lower doses and therefore more sedating. And so if the main issue is fatigue and sedation, it could be that the lower doses are having a bigger effect or that withdrawal is having the effect. I'm going to say I think it's a bit overstated. I as someone who's used mirtazapine for many years, mirtazapine was sedating at almost all doses for me. Just not saying it's true for everybody. But the way to distinguish it is to pause your taper. If you pause and wait, then if it's a withdrawal effect, it'll get better. Whereas if it's a side effect, it won't. So really, the only way to tell is to kind of take a break and see what happens.
And as a quick transition, since we just talked about pausing, for people that reinstate after protracted withdrawal, are there any ways that you recommend for them to be checking in or deciding when to potentially taper again? If there are clear signs, I know it's pretty nuanced and on a case-by-case basis, but here in the chat, it's been a pretty repeated question. So I just want to know if you have any advice for them on navigating timing.
So yes, all the provisos Emma's said are true. Everyone's a bit different. I basically think, protracted withdrawal means you've got a damaged or injured nervous system. And if you want to come off the drug again, you're probably going to cause a little bit more irritation. And so you want to have enough headroom to be able to tolerate worsening of symptoms. And so the kind of very rough rule of thumb I use is to wait for your symptoms to be 3 out of 10 or less before you do it. So that if things get worse, you've got ample headspace. Some people are impatient and want to get off before then, in which case I suggest doing it very slowly. That's the kind of rule of thumb that I use.
And then when you're talking about the 3 out of 10, are we talking about the DES?
No, the DES is sort of like, it's a bit specific. I'm just asking people to kind of rate their general symptoms out of 10, where 10 means I can't live anymore, I'm screaming in the streets, and 0 means I'm having the greatest time of my life. So 3 out of 10 means closer to being okay than being, terrible.
Thank you. And now there's one more question here on withdrawal symptoms before we transition into the rest of the questions for protracted withdrawal. Asked, why is it so common to feel deep fatigue during the process of antidepressant withdrawal or tapering?
Yeah, good question. I think there's lots of reasons. Look, I think you're changing the chemistry of your brain when you're coming off a drug. I think that can disrupt how well you sleep. It can disrupt your metabolism. It can affect your immune system. There's so many different ways that it can disrupt the normal rhythms of your body. A very common way is to cause insomnia, but I think there's just lots of different ways we don't quite understand. But deep fatigue is extremely common. And, I have the same answer for every major symptom. If you're having too severe symptoms, then either pause, go back up, go down more slowly.
It's a high touch process for sure. Now on the topic of protracted withdrawal, The first question, which I think is great for framing here, how would you define the symptoms of protracted withdrawal? And can you have mild protracted withdrawal, or is it typically just the cluster of those symptoms?
Yeah. So, there's sort of debate about how you define these things. But basically, protracted withdrawal is withdrawal effects that last for more than 6 weeks after a dose reduction or stopping a drug. So it just means long-term symptoms, and like any symptoms, it can be mild, moderate, or severe. So yes, you can have mild protracted withdrawal or severe symptoms. Just because you have it doesn't mean you can have it for years. Some people have it for a few weeks. Some people have it for a few months. Some people have it for longer. So it's a little bit, yes, there's a wide range.
And more of personal anecdotes here. I cold turkeyed off Effexor after 18 years. I'm 30 months off and still dealing with waves and lingering issues. Is healing possible?
I'm very sorry to hear that, April. I think this is, I should say, sorry to use your case as an example to other people, but this is a very good reason not to come off a drug quickly. Some people say, well, I'll just come off quickly. If I get into trouble, I'll go back on it and come off more slowly. I sort of think that's a bit like jumping off a building, and if things go wrong, going back on the building and trying again doesn't always work. Sometimes it does. I can see April saying she followed her doctor's instructions. So, it's very unfortunate that my
How
colleagues,
unfortunate.
very unfortunate is an understatement, that my colleagues are sort of giving this advice to people that is so dangerous because they don't understand the way these drugs work. Look, yes, healing is possible. We're resilient people, organisms. If we break our bones, they grow back. If we rip our skin, it grows back. The nervous system is more delicate than bones or skin, and it can take longer, and it can be much more devastating. I've seen people that have taken months or sometimes years to recover. Sometimes they have no recovery for a couple of years, then they have great recovery. Sometimes they have trouble with a few years, they have issues for a few years, and then things get better. I guess if you're having waves, it means you're also having windows, so it's a sign that healing can come. So I wouldn't give up. I've seen people that have gotten better after long periods of time. But I guess just to reiterate, this is a very good reason to come off these drugs very carefully so you don't get into the sort of trouble that April is. And there you go. She's saying, she's giving a kind of positive message there. She's much, much better, and she's been a lot better the last couple of months. So a bit of hope out there to people that are having trouble. But I think also a warning sign to others, don't jump off these drugs because the cost can be immense.
So right now we're currently talking about people who had potentially started tapering or going through discontinuation too rapidly. But if we talk about raising awareness to incept on the patients that are curious possibly about tapering, I know we talk about how the benefits of following the hyperbolic tapering approach, but I think there's also the psychological element of how do you know when you're ready to taper off a medication? Let's say you are considering it, it is something you genuinely want to do, but what are some of the things you've seen or insights from patients that you've overseen and guided through this process?
Yeah. It's a great question, really important, I think, for lots of people. How do you know it's the right time to start tapering? I mean, I'd say two things on this. I'll sort of talk out of, say, mildly opposite things. It's better to taper off if things are stable in your life. It's obviously easier to um, make changes if everything else in your life is stable. That's true for anything. And that's probably never happens for anybody on earth, kind of thing. I started coming off my drugs when I was highly unstable. I was extremely unwell. I felt terrible. That's when I started coming off, and in large part because I felt terrible because I was on the drugs. So if I'd waited to feel better, I don't know if it would have happened. So, I think the ideal answer is when everything is stable. But I think the second best answer is now. I say, if you do it very gradually, because I think also people have in their mind, oh, it's going to be very disruptive, it'll cause me all sorts of trouble. But if you do it very slowly, in this sort of hyperbolic way, you can do it in the background. It just so happens I tapered off over several years.
Process.
I worked full time, been fairly productive in the last few years. I've done whatever, I've traveled, I've done different things, whilst tapering, and my biggest regret actually in my, well, I've got several regrets in my life, but one of them is not tapering off sooner, not so, because it's improved my health so much overall. So I wish I hadn't waited so long. So I would sort of say, ideally, everything would be perfect in your life, but what about before then? So someone just said, what about pregnancy during? I'd say that's doubly helpful, because you don't want to go too quickly because you want to disrupt things. But if you come off your drugs during pregnancy, it means that your child, when delivered, will not go through withdrawal as much if you're on a lower dose. Maybe you've missed the first trimester when the issues about neurodevelopment are so relevant, but at least you can reduce the risk of withdrawal, on delivery to the child. So I think it's doubly useful to taper off during pregnancy.
I think this also transitions well to the follow-up on this topic for pregnancy and I guess greater topic of women's health. Oftentimes, the follow-up to this conversation of whether or not women should consider integrating tapering into their preconception planning or family planning, sometimes the response is, yeah, well, there's no research to suggest that it is dangerous, or there's no clinical research to say that, this is unsafe for me relative to whatever, like the depression I'll experience that my doctor told me I'll experience if I come off my antidepressant. There's so much to unpack in that language, but both from assuming that because you taper off your medication, your depression will come back, and in that the reasons that we don't have the clinical research on pregnant women that are on antidepressants versus tapering off. Can we talk about that a little bit?
So, I think this is one of the areas that I'm most disturbed by what my colleagues say, which is exactly what you just said, Emma. Stay on the drug during pregnancy because the risk of becoming depressed again is bigger than the risk of being on antidepressants. And I think that's a very problematic summary. So I'll just take each half in turn. So first of all, there are when they do studies of taking people off antidepressants and they show that people get worse, they're often ignoring withdrawal effects. The way they do these studies is they take a whole lot of people who are on antidepressants feeling better, they randomize them to either stay on the drug or come off the drug, and they monitor them for several months afterwards using depression scales that ask people, how do you feel, how are you sleeping, what's your appetite like? And in these studies, they find that people that stop antidepressants generally feel worse than people that stay on the drugs. But in these studies, and that's why they say, well, it's better to stay on the drugs. But in these studies, they ignore withdrawal effects from the drugs. If you feel anxious or depressed or irritable, like people have mentioned, then that's not seen as separate from the effects of the drugs. It's seen as a reason for being on the drug. So the analogy I would use is if you took people who were smokers and randomized them to either continue or stop smoking, and you measured anxiety and irritability, you'd say, well, people that stop smoking become more anxious and more irritable, and therefore everyone should continue smoking to prevent falling back into anxiety and irritability. That sounds absurd, but the same thing is being done with antidepressants. So I don't think there is good evidence that antidepressants prevent relapse, because all of these studies are based on these stopping studies, not on long-term comparisons of antidepressants and placebo. So that's the first thing to say, is it's very questionable if antidepressants do keep people well during pregnancy or other times. Then let's look at the other side of what are the potential harms of these drugs. Serotonin is sort of known for having a role in mood, which a bit is questionable. It's not as clear as low serotonin means low mood, but it's obviously involved in lots of things: appetite, sexuality, and it's also a transmitter that's involved in signaling in the developing fetus. So lots of chemicals are involved that tell this part of the brain to become the amygdala, this part of the brain become the left side, this part become the right side. And so there are lots of studies in animals that show that altering serotonin by giving animals antidepressants affects the development of their offspring in utero, particularly if it's given during the first trimester. There are studies that show it affects the social behavior of offspring in rodents. There are studies that show in human beings that there's almost a doubling in risk of autism in children that are the offspring of mothers that took antidepressants, especially during the first trimester. There are issues with fetal heart abnormalities. So the risk of having a heart abnormality in a newborn is 1 in 1,000 amongst humans, healthy women. And amongst women that are taking antidepressants, it's about 2 to 3 out of 1,000. So it's a doubling or a tripling of the risk of a fetal heart abnormality. It's not a huge risk, still 2 or 3 out of 1,000, but it is an increase in risk. There's an increased risk of pulmonary issues, lung issues in the newborn called persistent pulmonary hypertension of the newborn. It's rare, but it has been associated with a 2 to 6-fold increase with antidepressant use. Preterm birth is more common with an antidepressant. Postpartum bleeding, I've already mentioned that serotonin affects bleeding, And so that's true for women when they're bleeding after giving birth. Low birth weight, small for gestational age is also a risk for after antidepressant use. And then there's a withdrawal syndrome for the child on birth because the antidepressants cross the cross the maternal placental barrier, go into the fetal brain circulation, and affects the developing brain. I guess there's a great obstetrician in America called Adam Urata who says very simply, look, these drugs are designed to affect the brain. That's what they do. And that's also true for the fetal brain as well as the adult brain. And so those are just some of the risks. There's also some studies that show, poorer IQ, longer time to develop both motor development like walking as well as language development. So I think there are a lot of issues with taking antidepressants during pregnancy. And I don't think it's clearly outweighed by the benefits of staying on them. So I think that has been very badly misrepresented to the public.
Well said. And I think a way to recap that as well is whether or not you decide to stay on your antidepressant when carrying your child is up to the mother. But having all of the information necessary to truly make an informed decision is kind of that black box that we're missing right now in modern medicine, especially here in the US, where we're not giving everyone the information necessary to feel like they're actually making the informed consent decision to do what they think is right or best. And I think that's a good way also to maybe pause on this conversation. There's so much that we can cover. We have about 10 minutes. And when we have this next series of the Q&As, I also still want to keep time for the focus on women's health and kind of put together those questions. But for now, I think it leaves us all, especially so many of the women here in the chat and men as partners, parents, friends, siblings, something to think about truly about facilitating these conversations and making sure that the door is always open and that there's the line of communication maintains a lot of clarity and transparency so that we feel empowered and safe with the decisions that we're making for ourselves and for our futures and our children. We're going to go through for these next 10 minutes. There's a lot of questions to get through. I'd like to do a fun section. So I recapped about 50 different questions and put them into a myth versus fact section. So we're going to go through pretty quickly on topics by myth or fact. So, Mark, exercising for 30 minutes has been shown to be as effective in treating depression as an antidepressant. Myth or fact?
Much closer to fact than myth. So there's lots of studies showing that exercise has as big or a bigger effect than antidepressants. There's not as many studies for exercise because there's no money in it. There's no big exercise as there is big pharma. But most studies show, yes, the same sort of effect. Some people say, well, when I'm really depressed, I can't exercise. So there's maybe limitations to it. But yes, there's good exercise. There's good evidence for exercise.
Let's talk about the language here. If I failed at tapering once, I will fail again next time. Myth or fact?
Great. So myth, lots of people, I failed at tapering. Lots of people I've seen have failed at tapering. It depends on how you do it, of course. It's how you get off that top of that building. If you jump, in big bounds, you're going to get into trouble again. If you do it very slowly and gradually, it can be a lot easier. So I wouldn't count a failed attempt as meaning you're never going to get off.
Is medication the only solution for severe anxiety? And could it be helpful if used only in the short term?
Good question. I'll rely on the UK government guidelines for depression, which is very similar for anxiety. There are lots and lots of things that can help anxiety, not just medication. And also you got to think about the ways that they help. So, exercise, mindfulness, different forms of therapy, etc. Although I take a step out, the best thing for anxiety is to try to affect the thing that began the anxiety. So if you're anxious about work, relationships, there really is no way around dealing with those issues. So I think whenever people use the word anxiety divorced from what's causing it, it's always harder to answer. But, if you're anxious about financial problems, it's got to be some sort of financial solution. If there's issues with work, you're going to have to confront your boss about bullying or something. So to some degree, it depends on what's the cause. But if you want a generic answer, there's lots of things that are good for anxiety. Could it be helpful in the short term, medication? I think that's an interesting question. I think that what medication tends to do is to numb people. That's what people say in survey after survey. Is it useful to numb your emotions? Maybe it is in the short term. Certainly can be very problematic in the long term. And I'm not exactly sure if it is that useful in the short term because mostly that means it's harder to deal with the issues that are facing you. But some people might make that choice. I think it comes down to informed consent.
Well said. And just to add some nuance there for a lot of people, the reason I kept this question in the chat, and I know it wasn't depression specific, is oftentimes there's a bit of a fallacy that, you're planning on being on a medication short term, and the truth is it can be a crutch, and then all of a sudden you almost forget how to walk and feel confident in walking without the crutch. And then I saw someone in the chat say, yeah, I thought it would be short term, and here I am years later still on the medication. I just want to hold space for the fact that sometimes we think of what that short term plan looks like, but in execution, like Mark said too, it's like, what really is the benefit of numbing those feelings other than adapting to feeling numb, which might not inevitably help the underlying situation or feeling or struggle. Three more really quick for myth and fact. I just think this one's funny. It's a really quick one. My doctor says I can stop at the lowest dose capsule, so it must be safe.
Right. That comes up all the time. That the doctor says you're on a low dose, you can just stop it. And what they're almost always mistaking is the smallest available tablet or capsule for a small dose. You're using the word capsule. I'm guessing it might be Effexor or duloxetine, and the smallest capsule for Effexor is 37.5 milligrams, and for Cymbalta, I think it's 20 milligrams. But both of those doses have a very large effect in terms of effect on the brain. If you remember the curves I showed for Zoloft, there's very similar curves for Effexor and duloxetine. And that means that although, and your body doesn't care what size tablet or capsule you're putting in your mouth, it cares about the effect on your brain. And so for most antidepressants and other psychiatric drugs, the smallest available tablet or capsule actually often has 80 to 90% of the effect of the largest available dose. In other words, it's not a small dose, and that's why some people get into trouble, that they mix up small tablet and small dose, totally different things.
Well said. And I know I said we had a couple more myth and fact, but I'm actually going to hop over pretty quickly to just in these last 4 minutes. And again, everyone, there's so many more questions. We will be doing this again, but just some ones that really stood out to me that I just want to cover as well here. Why do you think there's so many providers that are still unwilling, parenthesis, I don't know if that's the right word, end parenthesis, to recognize this hypersensitivity as a real neurophysiological phenomena or acknowledge terms like bind even when patients describe profound suffering?
Right. I can see Tim in the audience has put in groupthink. That's probably a part of it. I think there's lots of reasons. I mean, I think to some degree, it's very upsetting to doctors if they realize that what they've been doing is causing great harm to patients. I think that very much challenges, their sense of self. I got into medicine like everyone else. I wanted to be a good guy, be helpful, have a worthwhile, productive career. If someone told me that what I was doing was causing great harm to people, and rather than helping people, I'd been doing the opposite, I'd be pretty upset about it. I'd sort of want to get that guy out of my office. I'm normally that guy in real life. So I think there's a lot of cognitive dissonance about it. I think they're also being taught, by their professors, this doesn't happen. There's sort of these talking points, and so I think there's a lot of kind of political, cultural reasons, and groupthink is not a bad description to Tim.
Okay. So for everyone in the chat now, we're going to start wrapping up. There's a couple of open items that I just want to cover in the next few minutes, but I do want to thank you all for asking your questions. Mark and I have a hard stop for today's, but this only comes to show that this is something so relevant and useful. I want to thank everyone for sharing and being so vulnerable and asking these questions. And I also want to shout out to a lot of the people that asked Mark questions actually also had beautiful testimonies and sentiments to share about your appreciation for the work that he's done and the relevancy of what it is that we're doing now and creating this sense of community. And I can't agree more or thank you all enough for vocalizing that. Tapering can be a really isolating experience. My heart goes out to everyone that's currently going through it. Finding that sense of community here on these webinars and even in the wonderful websites that are fostering the sense of community in the chats. It just makes it's a very good feeling, but mixed as well, because I was once also kind of there. Just so everyone knows, for the next session, things that we'll be putting a bit more time to, because we didn't really get to cover it as much, is how to stay motivated and perils of wisdom as you're tapering, or once you've fully reached discontinuation, the words of advice that you have for others that are currently on the journey, which is pretty exciting. And I'm very much so looking forward to it myself. And then also a bit more on, the neurological side or neuroadaptation side of like what is withdrawal, what is tolerance, how did we get ourselves here, and a bit more on like the science side. So I'm sure Mark will be really excited too to maybe share his screen a bit more and show us a bit more of the visuals. This was a preliminary. This was our first trial for everyone too, kind of expanding beyond the typical taper specific content that we were doing. So thank you all so much for giving us the insight that a Q&A session would be helpful. Moving forward, Mark is also going to be interviewing Angie Peacock, who I saw was also mentioned in the chat. So that's another one to look forward to, especially if we're talking on the perils of wisdom and insight and support that you can be finding for yourself and other in community as you're going through this process. So stay tuned for that. And then for anyone in the chat that was also asking how you guys can support Outro, just spread the word. It's about creating community. Try to knock up a conversation with people around you and create that sense of safety so that other people can also feel comfortable wherever they are. Even if it's not tapering, they're just going through it. We're all kind of walking each other home. So that's what you can do to help us. And if you want to promote our events or send them over to your friends, the next webinars, that would be great too. There's always something that we can be learning here. So thank you for letting me ramble. I will be going through the chat now because I was just blabbing away. But Mark, if you want to sign off and have any final words for everyone. Otherwise, we'll see you guys soon, and make sure you register for our next event.
Thanks for hosting, Emma. Nice to hear everyone's questions and happy to do it again. Always good to talk.
All right. Bye, everyone.